first part. So what we did in the morning was to discuss what your experience is with training and what you want to achieve from this course.
A little about me. I got my fellowship in gastroenterology in 2016, and then since 2018 I'm working as a faculty member. I'm a senior gastroenterologist at a university hospital. I am a CPSP accredited training center, so I train both the postgraduates as well as my unit has postgraduate trainees after the post-fellowship trainees as well. So I'm training them. My procedural experience is more than 1200 documented ERCPs.
But the training experience-wise, are you training? You got trainees at the moment?
Yes, I have trainees.
Okay.
I usually train one trainee per year in advanced procedures, but it was it was kind of a mix because I was also training myself. But for the last 3 years, I am independent, and I have trained two advanced endoscopy trainees. And one has become independent in level 2 ERCPs, and one I just currently took up for.
So what do you want to get out of this course?
The reason that I am here for is because I want to learn how to teach,
right.
how to because I'm very good at describing. But I sometimes tend to struggle, and it's sort of an internal audit that if I'm doing something, I'm doing it correctly or not.
Right.
I want to get it checked, and secondly, I would want to see that how do you people do it, and how do you people teach and train.
So, what was your objective again? What did you say? I just took a picture of your screen. So you also said improving
how to
teach skill
in a proper way.
Okay. And you say the same thing as well. So all of you said that's okay. Main objective is that you want to improve your teaching.
Learning myself,
Validating us.
Okay.
and then learning how to teach that.
If we go into a little bit of detail, so what is that you find difficult in teaching the RCP?
Actually, we know how to.
If you put two columns as a good and bad, one is that aspect, and then in the other segment we'll leave that open now, so that we'll come to that.
Sure.
On the other side, Nadi, if you start documenting what they find difficult in teaching, please.
Actually, we know how to do by ourselves. When pass the scope to a trainee or the fellows, at times difficult. हमें लगता है कि हम शायद do कर रहे हैं, मगर वो शायद हमें difficult to teach or we transfer the same words to the trainee. How do they do the same maneuver or the same? Let's say a trainee stands in a D1 or D2.
अच्छा.
मुझे पता है कि I can short with the scope like this manner, but at times initially it's difficult. You have to close the small wheel like this and have to de-loop this. This is teaching.
So difficult to verbalize your
Verbalize.
already.
करना आसान है मेरे लिए, but I think it's to transfer, to communicate the training is difficult. Similar other steps as well.
Yeah. So as Shahid said, so verbalization, every step, but also deconstructing.
Yeah.
So
Because
a lot of things we do, but we
Yeah.
deconstruct every step of
I think it's for 5 steps, but
right.
मेरे लिए एक ही step होगा, but for trainee I think it's 5 steps. 1, 2, 3, 4, 5.
Yeah. So you're deconstructing.
Yeah.
आपकी what is your
मेरे लिए जो सबसे ज़्यादा मुश्किल में because I have been trained many papers, so मुझे जो सबसे difficult part लगता है या dangerous part लगता है to start about the sphincterotomy. That is the most difficult part. Yani I fear myself as well as when I ask somebody to do. So that is the most important part. So that's
you find it difficult to teach sphincterotomy?
Yeah.
Why do you find difficult to teach specifically?
Because there is a risk of perforation and bleeding and all these things. So that's why I feel it has to go very smoothly.
Right.
But it is difficult to direct, to guide them. Although I did whatever I learned, how to do whatever I learned to do, I try to teach them. But still I feel that is the most difficult part. Otherwise, I could communicate to steer them through the pylorus or into the D2. But this is the most difficult part for me. Still.
Again, when it is difficult, if you look back and again, it's that when you tell them to stop or when
I tell to them stop, how much should they do the bow and how much tension should they put to them, and how much when should because now it is easier because of the availability of the pulse cut. It is much easier to instruct them because it stops itself. Pulse cut stops itself. But even then, I feel some fear.
Okay. So what is that you find difficult with training?
It comes from overall my experience because my experience in learning ERCP was a bit different because it was a mixture of self-taught, different courses that I've been attending, and then I've been, because unfortunately I could not get a chance to be formally trained in an ERCP setup. By formally trained, I meaning I've never enrolled in a 1 year or a 2 year post-fellowship program that teaches ERCP, which I can replicate. So what I want to learn over here is that what are the steps, as you said, to deconstruct a procedure and let my trainee know that you need to do this, then you need to do this. How, from the looks of it, I just want to break it down for them.
Right.
That's what
Okay. So if I get Shanil and Nadeem are expert trainers. So if we, Nadeem, I'll ask you to go back to a time when you were training. So if you can tell, we'll come to the trainees, one of the qualities of one of the good trainer you had, and one of the qualities of a bad, when I say bad or not a good trainer, what was your experience? Good trainer. When you were a trainee, go back to time when you were training.
So I think the trainer that comes to my mind, I'll use the example of Jonathan Green. I had this psychological safety of working with him. I never felt as if I am under a microscope or I'm going to be told off for not performing a task up to his standards. So I was very relaxed in his presence.
Right.
So I had that psychological safety. So I think
Somebody made you relaxed.
yes, exactly. So the whole thing I thought was this psychological safety that he provided me, that helped me to sort of no fear.
No fear. And somebody who felt was you didn't learn anything or made it difficult.
So the one that comes to mind is somebody where the commands were quite abrupt.
Okay.
So communication was there, but the commands were quite abrupt. So obviously the intention was to ensure patient safety. However, the commands were a bit abrupt. So the communication or the language, we probably were not speaking the same language. It was a different abrupt command.
Right.
So that is
That
where.
is-
So I think again
Again,
may come down to that aspect of
This-
communication.
communication wise. Okay. And Shanil, your experience?
I think the good one is a trainer who remains calm. It shows that he is calm and in control. Because if I have a trainer who is already stressed and he looks stressed, and then I am doing a ERCP with him, then I am already stressed because I look at him and I look at his stressed. And the way they show calmness is, some trainers you will find that they're standing on your shoulder, just next to it. As soon as he's gonna go in, I just take over. And that doesn't show calmness. That shows to the trainee, to me, it shows that he doesn't trust me. Okay. Secondly, if he doesn't trust me, then how can I learn from him? Secondly, it also shows me that maybe he's also not good in ERCP, that he's so into it that he thinks that if I do a complication or if I do something, if I do bleeding or something, then it will be difficult for him to stop, or if I cannulate 2 times, and it will be difficult for him. So good trainer, I would say, is somebody who's calm and who makes you feel at ease. That when you're doing it, say for example, even if I say for endoscopy and colonoscopy as well, so say if you're doing bleeding leader or something, you know, if I am not competent to deal with the complication, then I should not be teaching you at all.
Right.
Okay? Because as a trainee, at some point you will get complication. You know, even as a consultants, we get complication. So my job is that A, to prevent the complication from happening while the trainee is, and then secondly, if that does happen, I should be competent enough to deal with that complication. I should not be stressing out, as Salisha, you know, the first case he showed you, patient the wire went in the wrong way. He didn't say, oh, kya ho gaya. No, he took over and he did it. So that eludes confidence and shows to the trainee, okay, that's fine, complications do happen, but I have somebody who's got my back. Okay, if you have a trainer who's not got your back, then you won't have a good trainees.
We'll come to one other concept where he pointed out a very important concept in training is that your trainees, what is that they're worried about? When I give an example, when I'm wearing the gloves, your trainee is worried about that you will take the scope. That's one of the biggest fears for them. So we'll come to that concept specifically. We'll spend a few minutes of when to take over the scope. Okay, we'll discuss that in detail. Or we'll put this one point each for each one of you, and then we'll explore this aspects a bit more. आपकी example क्या है? Either you can tell me. You don't have to tell when you were a trainer. You can also tell me one of the your trainer. Why one of the trainees they've told you that you're a good trainer. What is that they've found that you're a good trainer? You can tell about yourself, or you can tell about your experience of training.
Trainer should be very patient.
Okay.
It's very important.
Okay.
Chandra said that trainer is also in anxiety or panic state. It's automatically transferred to the trainee as well. Trainer should be in a patient mode. If we observe something goes against his will or against the rules, then gently told, cannot give then it's shattered the confidence of the trainees. Just stop there, take the scope, correct the same step, and important is to give back to scope as well.
Exactly. Okay.
Otherwise,
so your good trainer is one who knows when to give back the scope. Yeah.
Scope, yes.
Yeah, that is.
होता ही है कि generally कि जब scope ले लिया तो ले लिया.
अच्छा. वापस नहीं देते.
वापस नहीं देते.
That's the fear for the trainee. दे दूँगा.
तो मुझे मिलेगा नहीं.
So once you give back.
That's very important to give confidence to trainee that if you make any mistake at any point,
correct.
Don't worry, I will correct, or manage to correct, hand over the scope again.
Right.
I think
that is very important when to give back the scope.
Yeah.
I think that comes to the point. One of the main point comes here is that before starting the procedure, you have a briefing with your trainee. Okay? Because when you have a briefing with the trainee, to say, look, when I tell you to stop, you stop. If there is any problem, I'll try and deconstruct it and tell you how to go about it. And if you can't go about it, then I'll take over. So the trainee knows what you are going to do, so that that fear, he'll take over and not give it to me, that resolves.
Have you had an experience? So that remember you were a training or something. You were a trainee. You did the procedure, difficulty. Right, I am the trainer. देखिए, दे दो मुझे scope. You just did it, and then you are just shocked. Wow, you're God. How did you do that? And then give it back to you. How did you do that? What do you think about that trainer? How do you feel about that?
Bad.
Huh?
Bad one.
Bad. Yeah. So
As a trainer, bad one definitely, because the trainer means that he needs to train us. He or she needs to train us.
But you've seen a lot of people who just say, I'm great, kind of, I'm great.
Just to show their greatness, yeah. Sometimes it happens that to show their greatness or to show off the people that it's so easy, but you are not able to do it, and this is the wrong thing actually.
So how does a trainee feel then?
Very bad.
Very
bad.
Very low.
Yeah, and also morally they feel very low. That still the confidence goes down. You can feel the shoulders drops.
The better thing is that अगर ऐसी कोई situation है, you do it, and then you encourage them कि सही ऐसी difficulty. I also while I was getting training, I had same experience. but this is what you will learn later on.
But
So this was-
sometimes when you've done it, like for example, as Sarisha said, if it's a difficult thing and you've gone through it, okay, then either when you're doing it, you deconstruct what you're doing and verbalize to the trainee that I am doing this, or if you feel that this is too difficult, let me just go through this, you go through it and then you tell the trainee, look, I did this, I did my hand like this, and then this is how I went in. So at least उसमें क्या होगा कि वो जैसे आपने कहा कि वो as a bad trainer नहीं होगा कि जी वो तो चला गया, ठीक है वो चला गया, हो सकता है कि that was difficult and he wanted to go in, or the procedure was prolonged and he wanted to go in, but at least he explained कि भाई next time जब वो इस position में, so this is what I did and this is what you should. So the trainee gets information for that as well.
That's a very, very, very good point, because not at that moment you want to concentrate. So you don't want to speak, right? We are humans as well. So you want to concentrate. It's not possible to deconstruct at that time. And it's also possible you don't know how to deconstruct. Every situation you would have done this. You don't know how to do it, but you took over and did it. But only when you are doing it, you realize what steps you did. So which you can verbalize afterwards. But आपको training से communicate करना बहुत ज़रूरी है. As he has put that communication and communication saying that okay, I'm going to tell you what I'm doing now, or you say I don't know what to do, but I'll see what I can do, and then you communicate with them after the procedure. Say that this is what I think I did, and probably it might work next time, because sometimes we might not know.
यही मैं कहना चाह रहा हूँ. Another aspect ये भी है कि sometimes you take the procedure because of the patient safety and all these things. You do it quickly, but again जैसे मैंने कहा कि either at that time, अगर उस time में possible नहीं है तो then later on you tell your trainee that this was happened, you were doing this thing, and I just did these things, so I got this success. So this is the way. But always do it. One point is that somebody want to feels other one make people that I am a superior person, and the other aspect is that they maybe because of the patient safety you did it, you do it, and then you later on, in that case you later on or at the same time you explain the
experience है कि हम सीख भी दवा सिखा भी दोनों टाइम से डॉक्टर साहब पीछे खड़े हैं, मैं कुछ चीज़ कर रहा हूँ, तो तुम सही कर रहे हो, गलत नहीं, इससे होता है कि करने वाले को सब बूस्ट मोरल हाई, ठीक है मुझसे नहीं हो रहा मगर टेक ओवर कर लिया, मगर ये क्या तुम सही कह रहे थे, ठीक है नहीं हो रहा, मगर we do cannulation, at times we are unable to cannulate, maneuvers सही होते हैं, कल सही होते हैं, मगर शायद लक नहीं होती, at times suddenly
थोड़ा सा रिफाइन होता है,
ठीक है एक्सपीरियंस भी होता है, उनका कहना कि तुम सही कह रहे थे, कुछ गलत नहीं है, it's things the few words आपको थोड़ा सा वो ट्रेनिंग को जो है वो एकदम कहते हैं ठीक है मुझसे तो दिया गया मैंने कुछ गलत नहीं किया, वो सही था, but
again communication and saying that you were there, but this is
good word or positive words,
right.
हो सकता है कि वो कुछ ना कहते हैं उससे ले लें इसको, if he says some good words तो ये होगा कि ठीक है मैंने दिया मगर मैंने गलत भी नहीं किया, तो ये positivity.
Yeah. So again, you can see here the things which we have to say is that one is the characteristics of your personality of the trainer. You talked about one who makes you feel calmer, relaxed, makes you confident, knows the limitations, and then you think about the patient who is patient focused. आपने कहा कि because patient safety वजह से आपने ले लिया scope, so you're patient focused, and then also trainee focused. You're wanted to make the welfare of the trainee. So and then most important aspect we first explored was that deconstructing the steps and verbalizing every step, which is the most difficult part in ERCP, isn't it? There's so many movements which we discuss, intricate movements. You have to do a tip up, sometimes you have to tip left and right at the same time, you have to do a clockwise body movement at the same time, you have to push the scope at the same time or withdraw the scope. All of these movements, you're doing intricate movements at the same time simultaneously. To verbalize every step is very difficult, and that concept, thanks Nadim, I'll just off this. So that concept in training is called conscious competence. Okay. Have you heard of that?
Yeah.
Okay.
Paul was here
so you learn the colonoscopy, you learn about that aspect, yeah. So, if you know the concepts already, then, and that's the hallmark of the best trainer. Okay, can you give an example of what is unconscious incompetence? Is that a train? What is unconscious incompetence?
Sorry, unconscious means
Doesn't
know and doesn't know how to teach, and doesn't know how to do and doesn't know what to do.
Okay, I'll give you an example of my own experience. I was an SHO, right? Being a junior doctor in UK, right? And then my registrar was, I was in a gastro posting. My registrar was doing a PEG, and this is 20 years ago. And he was doing both the sides on his own. He had done the endoscope. He was also doing the abdominal part as well. And he was struggling. He was holding the scope. He was cutting this. And then I walked in to ask about a ward patient. I'd never seen PEG before. I don't know how it is done. And I walked in and I said, "Can you help me? I'm struggling." I said, "Okay, what do you want me to do?" He just said, "Pull it." He didn't tell me how much to pull. Or he just said, "I don't know what to do." I just said, "Pull it." I pulled it.
So
And it
completely.
No, it pulled it. It came out of the. It was in the peritoneum, right? So that's an example. And first of all, if I look back, that was completely not indicated. It was a 90-year-old which we did, a frail patient. So I was unconscious, incompetent. I don't know what to do. No idea. And then you are asking me to do something which I don't know how much pressure to put, what to pull, where to pull. And that's unconscious incompetence. We don't know anything about the procedure, don't know anything. The next, where are the trainees? You know, the trainee like you, most of you who will teach tomorrow. No, that was mine. I was
just for the orders.
correct. As a trainer as well, he doesn't know anything about me.
Yeah.
As a trainee also, I don't know anything about the procedure. I'm incompetent, right? And I also don't know what to do as well. I don't know anything about PEG. I don't know anything how it's done. I've never seen how it's done. I don't know what experience you need to do this. So I have no consciousness about this procedure as well, and I don't have any competence as well. So that is where I am in. But most of the trainees, like the one who has done about 15, what are they? They know, they've seen the ERCPs, they've seen how difficult it is, but they don't know the intricacies of it. But they've seen how much, they have some knowledge now, what ERCP is and how difficult it is and how much you might need to do to reach there. So they are in, all the trainees are with me this year. This is not a trainee at all. I'm not even thinking of doing PEG. You put me in that pressure situation. So, but the trainees are here. The trainees are here. They're conscious of course that they know what they need to do. They know about ERCP, but incompetent. So that is fair enough. That is where they are. But once you're training and like Peter Cotton or whatever, so they all learn by themselves, right? Because this is concept, we are only doing it now. From here, where do they move to? They move directly here. So they do thousands and thousands and thousands.
Unconsciously competent.
Yeah, so it just becomes like if you're driving for same route every day, you will forget how I reached till the hospital. You just reach there. So you've come to this stage where you're unconscious incompetence, conscious unconscious competence, and that's what most of the trainers were of previous generation. You struggle, they take over the scope, they do it, and then give it back to you. But they can't explain how they did that. But the reason why you are here is that we all have to reach here and remain in that state continuously. For example, because I do this every month for the last 10 years, if you just show me a video, I can tell you every step of what's happening just video of the endoscope image, I can say that because I do that every month. So, but that is where we need for all of us to be in for the where the trainees is. So that's the concept of the what is conscious competence, and that's where one of the good aspects of it is what we discussed. Then we'll just go most important aspect which we discussed also is taking over the scope, right? Or also what's called as a TOTS. So when do we take over the scope? When do you take over?
When I was being trained in ERCP, it was a simple rule of 3.
Right.
It was 3 attempts on the ampule, 3 attempts, conscious attempts. 4th was not allowed. Or one single pancreatic duct cannulation. That was when the scope was handed over to the trainer.
Right.
To the trainer. So this was the stopping rule.
Okay.
Or if 15 minutes had passed and neither cannulation has been attempted nor the position has been.
Is that a good rules for taking over?
No, that is why I was not comfortable over there, because at times I found myself hurrying into it.
Exactly. Because I remember my trainer saying that you'll be sitting on the computer doing whatever you want. You have 5 minutes, do whatever you want. At the end of 5 minutes, I'll come and take over the scope. You have not reached it. Is that helpful for the trainees? Having a time-based, time-bound targets. Yeah, it's not helpful, isn't it? So but when is the right time to take over the scope?
So what I do, I can tell you my experience. I have taken off this time bound from there.
Right.
That was the first thing I did. And secondly, I asked them what they're doing. I asked them for what will they do next. Now that this has failed, what is their next plan?
Right.
And then I make sure that they do it. And then I ask for a fallback plan. If that doesn't work, and then when there's my third question. The third question is that, are you out of ideas now? And when my trainee says that I have no further modifications or any other idea, then I take over.
Okay, when the trainee says I don't have any idea, what is the next ideal step for the trainer? What is the next step?
That is what I want to do.
Right.
Because what I do when I take up the scope.
Right. If it is possible.
No. Sorry. What you're talking about is those times while the trainee is executing the idea, I am guiding them.
Right.
In the meantime, I have not even gloved up yet. I'm just I've taken up a lead and I don't take up the gloves because I have seen that the trainees are more comfortable when I'm degloved.
Okay.
There because probably they know that I'm not in a hurry to take up the procedure. So when that is done, I keep on guiding them that you're overshooting or you're undershooting.
Okay, you're guiding them, but they can't execute to take over. Right?
And when their ideas are out and they are unable to follow or execute what I'm saying.
Follow what you're saying? Yeah, okay.
And then I take over.
Any other situation where you take over?
No, honestly speaking, I don't have any rules. I just assess the patient, I just assess the training. At that time, I taught them, I try to teach them, I try to guide them. I see if they follow, if they can follow, it's okay. If they are not following, then I try to teach them, this is how you have to do. But if I feel the patient's, like if I feel the ampula's position is not good, and I know this is the trainee's first 3 months, so I don't give them much time. I just take it and tell them that this is the problem with you, and this is the problem of the position, this is the problem of the patient, so that is why I am taking. So honestly speaking, I don't have any rule.
Okay.
But this is what I am trying to learn here.
Right,
If there is any rule, but this is how I do. If I have a senior trainee and I give them chance to do it, and during that time, gloved, I tell them that I will take when it is not going to happen by you.
Okay.
So don't worry. Just try it the way that you have learned, or try the way that I am teaching you. Just go it now, align the position, make sure that you push advance or push the, so हम तो कहते हैं अंदर थोड़ा सा और करते हैं उर्दू में बाहर pull करने, that's the thing. So if I feel कि मैंने उसको बता दिया है सब चीज़ और जो है वो फिर भी नहीं कर पा रहा, that is the point. या फिर जो है मुझे लगता है कि ampulla जैसे short बहुत ही small ampulla है, and if it is touched once then it will go into spasm. So then I feel कि भाई यार ये मुझे करने दो. And then again the situation of the high risk patient है या क्या है, so I just want them to make the position and then take over. So there is no such rule I am following.
So then both of them mentioned about they said something to give the instruction to the trainee as much as they could. What? But the trainee couldn't follow it or couldn't execute. They've taken over any other situation.
It is same situation. Which is comfortable. Trainee is doing the right way in the proper direction or the proper जो कह रहे हैं वो कर रहा है. I think it's better to give some time to trainee or trainee. It's like when I was in training, I'm trying. जब मैं नहीं होता किस तरह आप करते हैं, वही चीज़ मुझे अपने जीनोस्कोपी का ट्रांसफर करनी है, क्योंकि I'm attempting the cannulation after positioning. When I attempt 4 or 5 times, नहीं होता. I feel exhaustion. Sir, आप दे दें. क्यों? कि sir is comfortable, sir sitting, seeing me, instructing me. I think it's better to give some kind of training. That's very important.
Right, okay. So I'll give one scenario. I think most of the time you talk about the same thing, but there was another scenario I can give you. I remember my trainee, who was again experienced one, who just said, I can't see anything, right? I'm inflating, I can't see anything. So then what's the CO2 is on. I'm putting the air button on, but I can't see anything. So what is that situation? What do you do then as a trainer? It's just blank. The screen is just, you can't see anything there.
We have a checklist for that.
Yeah.
We start with checking the equipment first.
Okay.
If there is something wrong, the air is leaking or the inflator is out of place. So first thing is equipment check. Secondly, when this is the case, that is the time when the bells start going up. If the equipment is fine, we're most likely looking at a perforation.
Okay.
And there's a chance that the air is leaking out and we are unable to inflate.
Right.
Over there.
Okay, so you've done the checklist, but you still don't know what it is. So what I'm trying to say is that you don't know what the problem is, right? So when you don't know, do you know what the problem is? Right, in his situation, I've done all the checklists, I didn't know what it was. And as you rightly said, I didn't know he was in the mediastinum at that time. So initially, before I held the scope, I didn't know what the problem was. So it was important for me to let me take the scope. So do you know what the problem is? If you don't know, that's the time to take it, right?
Yes.
So sometimes you know what the problem is, but do you know what the solution is? What to do? You don't know sometimes. You're clueless how to, so
So that is another time to take.
that's a time to take. You know what the solution is. You know what the solution is, but you are here because mainly you can't deconstruct every step, right? That's the reason why you are here. You can't verbalize your state. So you know what the solution is, but can you instruct?
Yeah.
Can you, okay, so do you know how to instruct to give every step instruction? So you don't know how to exactly execute. So then you take over, but then you say to the trainee that I will try to tell you, I don't know what to do, but probably I can do it. While I'm doing it, I'll explain to you, or after I finish it, I'll explain to you. That's where your verbalization is not very sleek yet. You know how to instruct, you're given an instruction, but can the trainee follow it? Okay? Or more important than that, can the trainee understand it? As Nadeem was saying sometime earlier, because sometimes there'll be cognitive overload sometimes. So there's so many things happening. You're saying something, they're not able to understand it. Then you take over at that time. Then you come to this next level where the trainees are very experienced and you give all the instruction, or it could be a very junior trainee as well, so you've done all the right things, but he can't follow it, or sorry, he can't execute it, mainly because of his lack of experience. So you've done all the right steps, but he can't execute it because you tell them that, don't worry, the only reason why you're not able to do it is because you don't have an experience right now. I'll just take over, I'll exactly show you how to do it, and then I'll give it back to you. So these are the times when you take over the scope, but it's important to communicate with your trainee as well beforehand as to when you do that, you're going to give the scope back to them, and that's very important and reassuring for the trainee. Any questions here? So that's just to give you some understanding of.
Can I take a picture?
Yeah, sure. No, we can. Sorry, we don't. You know what the solution is. We can give you we'll send you all the slides. We can send you the slides.
Thank you.
Okay. Alright.
In some ways, good because then you can deconstruct in your head what are the steps and how you're going to sort of approach a trainee who's typically. In fact, your earlier point was quite important. If you've got a patient-centered approach and your objective remains the same, then if any harm comes to patient, obviously that is the time on which to take over. But otherwise, if you deconstruct as a session laid out, then at least becomes more obvious to the trainee and yourself that you're actually intervening at the right time.
Okay, so now we'll come to the concept of how much time we have. So we come to the concept of objective setting, right? So you have to set an objective with your trainee, and that depends on. Sometimes your trainee comes for the whole year, and you know that this trainee is going to stay with you for 1 year. So what discussions you have with your trainee at that time is different to when the trainee, where you set an objective for either for that list, or you're setting an objective for next case, okay, for one case. So your setting of an objective with your trainee varies between all these scenarios. So, for example, we asked you, what was your objective for the course? What is that you want? What is it all of you said, most of the things?
Learn how to treat, how to teach.
How to teach. How to teach. How to teach.
In a proper way.
Okay.
Teach to not in a proper way, in the right track, right direction.
Right. But if we look at the time we have, we are here today, tomorrow, is it possible for me or for us to teach you exactly how to teach ERCP properly? Is that something realistic?
Impossible.
Impossible.
Even impossible.
Yeah. So then, as the one who's we are running the course, is that a good objective which we can achieve? Not really, isn't it? So any objective which you do with a trainee similarly has to be something
Has to be realistic.
realistic, and we should be able to achieve that, right?
And it doesn't have to be the same objective, because if you ask a trainee, everybody's objective will be, I want to cannulate. Okay? So it depends on the year of the trainee, how many scopes ERCPs he has done, and then you simplify it, because obviously everybody has to do their list, his time and everything. So you simplify it, say, look, this case your objective is going to be cannulation. This case, next case, your objective is going to be putting a stent. This case, your objective is going to be, so you do the other bits that are not the objective, and then when you reach that point, then you say, look, your objective was this, now let's focus on that. So in that way, what happens is that if you have 20 minutes or 30 minutes for a case, you're giving the trainee 10 minutes to achieve his objective. The trainee feels that mujhe enough time mila and they gave me an objective and I tried to do that. And then you are also not rushing, we are running late and then the patient is sedated for such a long time.
Yeah. So what we're discussing is that I didn't question you or in that time, because I want to highlight that in this room about when we look at the objective of the basic trainees, they all said to cannulate. So your objective, we should ask the trainees to move away from your objective should not be where you reach. The objective should be about the journey, right? So we should try to cannulation is important, but before that, what is that you're finding it difficult to cannulate? What position. So I struggle to keep the position in, or I fall back. So you need to go into much more detail and try to say that we'll achieve that aspect of it, and then finally you will reach the destination. So it should not be a destination based, but it should be the journey based. So similarly, so it should be what we call as, have you heard of this? SMART? Yeah. So what is S?
Specific.
Yeah. So it should be very specific. So from all of you, if you say, I want to learn how to teach, that is not very specific for in the 2 days, right? And we can't measure at the end of tomorrow whether you have become an expert in how to teach. But rather, if your objective, I can tease out and say, we teased it out during the process saying that you wanted to deconstruct, to verbalize, that probably we can achieve to some extent. You can deconstruct that. So then it becomes measurable. How do we measure that? Whether you'll be able to deconstruct. So you're doing some model training today. We'll do some live cases tomorrow. We can see whether you are able to the concepts which we have done by the end of tomorrow, whether you manage to deconstruct a little bit. We can measure that. We can see that. And whether it should be achievable, yes, I think we will be able to achieve that by tomorrow, the concepts of it. And that is much more realistic. Or we can say whether your objective could be when to take over the scope. Then it is much more realistic, having a realistic objective rather than teaching the whole of how to train. And whether it's timely, yes, in 2 days we can probably achieve that. So that's very important to have that with your training. For example, we'll just do a kind of a scenario. That you are a trainer, and Nadeem will become your trainee. Just play around a little bit.
Okay.
So
First year training.
he's a first year trainee.
Post graduation.
He has done 5 ERCPs so far, and he wants to have a discussion. He's coming to your list now, so you want to have a discussion with him.
Let's just suppose that we are doing our simple case of choledocholithiasis. So, first of all, I would.
No, you just have a chat with him. Have a chat with him.
Okay, Dr. Nadeem, do you know what case are we going to do today? Have you read about the case?
I was told it's a patient versus stone disease.
Okay, so when we're talking about a stone disease, what is the management that you're looking for to give to the patient?
I think we wanted to get rid of the stone for the patient.
So now that you know know your objective, so what is your experience regarding removal of those stones?
No, I've only done a few ERCPs, 4 or 5.
So are you familiar with the whole process?
I've seen my trainers doing it, but yeah.
So you are at an observer level.
I've been sort of playing with the scopes, and I've had some exposure. But,
are you familiar with the duodenoscope?
familiar? I've just done 5 cases, well, few cases. So yeah.
So what was your level in those few cases? Were you able to take the scope through the throat?
In 2 cases, I was able to get this also, yes.
In those 2 cases, when you were able to take the scope, can you remember anything about the 3 which you were not? What did you find difficulty in?
The patient was struggling, so my trainer took over.
And when you went inside, did you have any difficulty while moving around in the stomach?
To be honest, I wasn't sure what I was seeing, so I couldn't actually see what was so I found it quite overwhelming experience to begin
And
with.
were you able to identify the pylorus?
No, I don't think so.
In these 5 years.
He was always struggling to go in. He was looking at the fundus all the time.
Okay. And have you ever been able to intubate the duodenum?
Well, I just pushed the scope down, and one
You
case
luckily landed into the duodenum. So that happens with all of us. So first of all, what we're going to do is that we're going to break this procedure down, and first we're going to work on your scope navigation through the upper esophageal sphincter. And first of all, when you will be going in for the procedure, our whole target will be to guide you knowingly into the second part of the duodenum, which starts with intubation. And I'll tell you a few techniques in which where you are going to how you're going to position the scope while entering into the patient, where you will take the scope inside, what will be the wheel movement, and then followed by the body movements. Because you said that you were going into the fundus a lot of times, so we will try to identify why are you going into the fundus, and when you are into the fundus, what you can do to bring it back into the correct position where the pylorus is located, and when you are going to, when we are going to achieve that, we will try to go into the second part of the unit. So for this case, this is going to be fine.
When we take the stone out?
I don't think so. This is the time to take the stone out. So first we need to work on scope navigation for this case.
Okay, so I'm not taking the stone out.
Probably not with this level of training.
Okay.
Because the first part of, the most integral part of ERCP is bringing the ampulla into the position. And before bringing the ampulla into the position, we would
So
like...
Can I get the in front of the ampulla?
Yes, first you have to get into the duodenum and then position your scope and bring it in front of the ampulla. Once we are able to bring the ampulla comfortably in our way, then we are going to attempt cannulation. So this part.
So if you want to summarize, what's your objective setting for us? Let's say two or three objective setting for a...
First objective is getting through the scope through the upper esophagus.
Okay.
Second objective will be navigating into the stomach. Third objective will be going into the duodenum. And fourth, there will be four objectives for this. That is going to be positioning of the ampulla in the correct way. For a trainee of this is what I would do if he's a trainee with this experience.
Okay. So is just you comment? अच्छा.
आपने जो शुरू में किया था वो तो बताया था you have done 5 ERCPs. So, but this is what he initially said. And then when you started asking the question, he said कि दो तो मैं अंदर चला गया, बाकी तो. So why did he say this is 5 ERCPs?
I think we were building on the history though.
No,
this happens. This happens.
क्योंकि ये जो है basically एक तरह से false statement.
This is not false. I was just recently had a chance to study
नहीं
this.
मैं ये जैसे ये कह रहा
What I'm
हूँ
trying to
जो ट्रेनी ने आके कहा that was a false statement.
Yes.
To give an impression कि जी मुझे पता है मुझे ताकि अगला काम करने दें.
This is an innate human ability. That was what I was reading about, and I was surprised.
No, but that you try to tease out in detail. So when you say 5, you try to say in which, how many you managed to pass, and once you managed to pass, what difficulty you had. So you try to tease out much more. But again, when you so it is hard, isn't it? So to try to do that. But again, was it completely realistic what this objective setting was?
In this case.
In this case, so you had 4 objectives. You said you wanted to get into the esophagus, then we'll say try to get to the stomach, then into the duodenum, and then come in front of the ampulla.
Objective in this next 3 months away.
No, for this case, never discuss it first.
After getting this, we will see that how much he was able to achieve in this case, and then subsequently build on to that.
I think just to be more critical in the sense, again, it was the objectives were big too much.
Over enthusiasm.
Isn't it? So somebody has done just 5, who has managed to just intubate twice. So again, what is this? The trainee is always asking that I want to get the stone out, right? You know that, and then he said, can I just look at the ampulla? That is again still unrealistic. So I think sometimes it's important for us as a trainers to say that, well, you still got a lot of time, you'll reach there. Let's keep it simple. Even I've not seen how you've intubated. So let me just do the intubation first. So if it is easy, and because the intubation is the most difficult part to teach, because you're not seeing what exactly is happening. It's very difficult to verbalize every step. So sometimes it's easier. How we train trainees now with intubation is that if I've never seen a trainee who has done it, I said I will intubate, right? And then once I intubate, I will tell you what steps I did. And if it was an easy intubation, then I'll take the scope back and give it to you. And then you do it. But if it was a difficult intubation, patient was already struggling a lot, then I think if I take the scope back, I might struggle yet, so I'll continue. So we have done that in a different way because we have cases over the years where they had perforation, but by following this, we said, I will do it first, and then if it was easy, I'll tell you exactly what I did, and then you verbalize, and then you do it yourself. And then by this, what we have found is that by 20, they're able to do that, and then don't push anytime. If any difficulty, then only I will take over.
So what I found is with quite a few trainees is, which is exactly coming to conscious and incompetent. And so I tell them that when you are doing a gastroscopy, I want to listen to how you are going in. You verbalize, don't shout out loud, verbalize to your ears that I am doing tip down, now I am doing clockwise maneuver, now I am straightening my tip and going in. And I've done it with 3 trainees, and all of them have said that once they started doing it after 20-30 patients, the intubation with ERCP scope was completely different. You know? They were completely able to do it. Before that they were not. Because they were verbalizing it, which is what we are doing, because they are verbalizing it, now they know unconsciously, they know how to get in, but consciously they didn't know what the maneuver was, so they were verbalizing it to break it down, and then when they did that with the ERCP scope, they were able to go in without any problem.
But again, this will come with your experience as a trainer as well, in the sense that the objective setting wise, when you say it's difficult to get in the pylorus, you can explore it more. That will come with your more experience with training. What is that you find difficulty in getting the pylorus? So they might say that every time I'm trying to push, that I can't get in. Right, so why is it a couple of times you go in, what is that you can do to get into the pylorus? What position you're in? Can you talk about what position you keep in to get the scope in? So you can try to get into more detail, but that comes with when you're confident of verbalizing and deconstructing the step. Why is that you always keep going into the fundus? When you come to the stomach, why do the trainees always keep looking at the fundus?
Yes, but because of their natural scope holding position. Because
or what happens is as soon as they come into the GOJ,
they forget
they'll tip up.
They forget to turn right.
Yeah.
That's what it is.
Okay, so what you do normally is that you tip up completely looking at the fundus. So what you do is you pull back the scope, right? So if you look at the gastroscope itself, as soon as you come to the GOJ, while you're pushing the scope in, a bit of an anti-clockwise movement. So you come to the center of the stomach, and now if you get a clockwise movement, so if you keep following this, you will never go into the fundus. So let's just work on that, right? So for this case, just work on that aspect. So you can have just one objective setting. So you have never seen you intubate, let me intubate for you, and let's focus just on that. So if you manage to do that, great. So you've never looked at the fundus, that's great, you achieved it. And then if you're going in easily, let's work on the pylorus. Now let's forget about ampulla for the moment. So you can do that. So you can have a segmental training, even on like somebody very experienced, and then he says that I want to do I struggle with stone. Every time I'm taking the stone out, my wire falls up. So then if you have a limited time, you can have a segmental training. You can say that, well, okay, if it's a busy list. If you are struggling to cannulate, I will within a minute or so, I will verbalize, but if you're struggling, I will take over. I will even cannulate and do a sphincterotomy as well. But I'll give a lot of time to just on the stone management.
So for me, it could be, depending on the trainee's experience, it could be short, could be short and specific.
Correct.
Rather than just specific, short and specific measurable outcome. Okay, so I've given, as Sarisha said, I've given him a short thing that, this is what we're going to work on, intubation. Okay, once you've done intubation, then, because you have to run your list, you have to see the patient and all that, so you can't let the trainee do all the 5, 6, 7 things whichever he wants to do. So specific, that's fine, but depending on the year of trainee, short.
Is there any what you can say, a guideline or some way to objectify all of this? Okay, like वैसे तो please no you cannot do that. No.
This is what you asked.
The issue is that the reason trainees get disappointed is because, as she said, your objective is too large. So in this case, I want to intubate, go into the pylorus, want to see the ampulla. So what happens is, that rapport that we were trying to establish, we lose that rapport. So when you set up to starting point is very clear. There's a clarity. There's a clarity in my mind as a trainee. There's a clarity in your mind as a trainer. Now we've agreed on what we want to achieve is. So there's a clarity. You have set the expectation. So you set the expectation start. Listen, this is what we are here to achieve. This is the expectation. So if I have an expectation to intubate, pylorus, cannulate, then my expectations are unrealistic. And I am not going to benefit from this training session because there's no clarity in my head. My expectations are completely
and then that disappoints you as well. And then also if you say, oh, stone, don't be crazy, that also disappoints them. You can't take the stone out, rather than say, no, you will reach there. You've got a lot of time yet. You just started. But let's not focus on that. Let's work on one thing, let's
achieve today's objective. So
right.
now.
So I think that's again coming to that. This is a really good tool. When you say guideline, this is the tool. You can adapt it to depending on your case, or if you might be doing the whole month, so you can have an objective.
This is what I'm asking. If this is the scenario we discussed for one case, but if I have a trainee who is here I know he or she is here for 1 year, or I am here for this week, other week as well. So I can tell them, or the whole department can take the trainee as a whole. If the first step is that, as you said, you have to learn the intubation, or you have to learn through navigation in the stomach, and then I definitely stepwise give you the. If we think that you have achieved this level, then we will go for the next step. So we divide these things initially at the time of training. Okay, this is how we will train you, and that's your competence as well, your concentration, your work. You have to understand the things. So if you achieve this step, then you will go to this. So it would be a good idea.
Yeah, your discussions with the trainees will varies depending on what you are saying, because our fellows comes in sometimes, or a trainee comes in and says, I'm going to be here for a year, and then he said, I've done 50 ERCP so far, and then is expecting that I will do an ERCP and he is done by the end of the year. No, it's unrealistic. So just put that in I don't think that is a realistic. So probably you might get some experience with years, but you'll not be there wherein you are completely competent. With ERCP, yes, by the end of the year, you will get some experience, but you'll still need 1 more year of mentorship and so on. I think by the end of the year, you will not be there. By 50 ERCPs, you won't be there. I think you might need some fellowship afterwards. I think putting that kind of a realistic expectation in them, that what they can achieve in that year, and then what more they will need after that, will also help them. And then when you discuss for that, what you discuss for that list or the next few months, to that case, varies.
One of the things that when we do the TTT for colonoscopy is, debriefing afterwards. So, whatever the trainee, even if it was just intubation that the trainee did, once you've done the case, you need to have a few minutes with the trainee to debrief. Even if they could not achieve intubation, at least you have to sort of buck up the trainee to say that this is what you did right and this is what we're going to do next. So for the next case, we've already made our objectives that this is what you could not do, so we will do this next time. So it gives a confidence to the trainee that, okay, that's fine, I could not achieve, because it's very disheartening, I'm trying to learn ERCP, but I couldn't even intubate. आगे जाके मैं क्या करूँगा ना? तो sometimes I remember when I was trainee, I used to think, oh, colonoscopy is the worst procedure. I can never ever do colonoscopy. But then you achieved it, and now you think that colonoscopy is not as bad. So as a trainee, because they're doing new for them, if we sort of debrief them later on, it just gives a bit of confidence.
इसमें एक चीज़ और है जो मैं अपना पर्सनल एक्सपीरियंस जब भी इस किस्म की किसी वर्कशॉप को अटेंड करते हैं जाते हैं, जब आप जाते हैं तो एक किसी चीज़ में भी एक नए जज्बे के साथ जाते हैं, बट यूजुअली वो जो है ना परसिस्ट नहीं करता है. जैसे ये वाली डीप ब्रीफिंग वाली जो बात है, अब आपके लिस्ट होती है, आपके पेशेंट्स होते हैं, यू वुड नॉट बी एबल टू, यानी एक जो अभी आपको जैसे यहाँ पे सिखाया गया या पिछली उसमें भी कि आप एक प्रोसीजर के बाद बैठते हैं फिर उसके साथ और उसके बाद उसको करते हैं, या एक लिस्ट के बाद बैठते हैं आप और उसके बाद उसको डीब्रीफ करते हैं. मेरे पर्सनल एक्सपीरियंस है टू बी ऑनेस्ट कि मैं नहीं इसको कर सकता, तो उसका हल मैंने ये निकाला है कि ठीक है मैं थोड़ा बहुत उसको वो साथ में डीब्रीफ करा प्रोसीजर के दौरान ही, जैसे आप दूसरा कर रहा है वो बैठा हुआ है इधर मेरे साथ है, तो मैं बता देगा यार इसमें ये चीज़ हुई थी तुम्हारे साथ ही. सो परहैप्स मैं this is what I can do. Right.
So that
should not follow the all each and everything.
Correct. You're completely right.
I have a little hack for that.
यानी improvise कर लेते हैं थोड़ा.
Improvisation उसकी ये है कि while you've done the procedure, उसके बाद जब आप report कर रहे हैं, मैं तो उसी वक्त ही debrief कर देता हूँ.
So we'll come, good, you brought this important topic, now we'll discuss about feedback. What you are talking about debrief. So what are the concept of feedback? एक छोटा सा exercise करेंगे, आप इधर बैठिए. आपके पीछे एक पोडियम है जिसे देखना है आपको, पोडियम के ऊपर. Superb, how good you are. देखा आपने, just पोडियम की just close, it went and fell. You're so good. How was that feedback with him? You're talking about, not about him, you're talking about the feedback I gave it to him. Think about it. How was the feedback?
It was encouraging feedback. That's what. It is little bit exaggerated.
Exaggerated.
I don't know.
Yeah, sorry. Do it again. Yeah. What are you doing, man? You're crazy. You know what it did? It went quite far away and hit nothing, not on the podium. What are you doing? What was that?
Realistic one. Realistic one, that's what we do it.
That's what you do.
This is wrong. No,
Yeah, so quite insulting.
Insulting, discouraging, yes.
How does it feel? You know, she says, sorry, I'm experiencing.
That's
Yeah, sorry to do that, but you know, how does it make the trainees feel? Suddenly you lose your temper and then.
Everything is gone.
Yes,
Whole learning
so
experience.
morale is gone, you
Correct.
just,
Yeah,
you see that
it's very shattered.
shattered.
Yeah.
But the first one, again, it went quite far away and you're just encouraging him. It didn't help you, okay? But now I'll tell you exactly what to do. So I think the first time you did, it just went slightly to the side. What more information you want from me?
How can I do this in proper way?
Okay, so what information you want? You did it twice now. What more information you want?
I have to learn which direction.
Okay, which direction? What you do is just move your chair slightly to your left.
Left.
Yeah, no, correct. This side, yeah. To your left.
My left.
Yeah, so move your chair slightly to other way. No, other way.
नहीं, ऐसे clockwise. This one.
So आपका left हो गया.
No,
आपका left हो गया.
that was important. The communication.
Iधर right.
You're not in the scope. आपके right.
Left पे जाना है.
Left. Just move this slightly this way. Yeah, I see. So use the same force, but not to you were more on onto your right side. So try to keep it in the center. Go above your head. Yeah, just a little bit. You're almost there. Just one more try. So you need your trajectory was a bit low. So it's slightly upper se jana. So just little bit of a trajectory on the above. The same amount of force. Try onto your left little bit. You went to the right. Just little bit straight onto your, move your, again little bit to the left. Same kind of trajectory. A bit far. So again to the other way. Just one more try.
Yes.
The same directions, but straight.
Oh.
Okay. Almost close. But even if they're failing, but when you say you did all the right things, but you couldn't achieve that mainly because we're experienced, now I'll take over. Also to know when I need to take over and do it. It's also important that, isn't it? So, yeah, thanks. So then that's kind of a feedback. We're just exactly verbalizing and exactly telling them, breaking it down and telling what to do. So there are two ways, different ways of giving a feedback. And you know any methodology of giving a feedback?
Sandwich.
There's one is called as a pendulum feedback. It is
Sandwich technique.
okay. People don't think it is very realistic. Just the reason why you were. What is it much?
I think somebody is starting that.
They're doing the basic, so they're doing the dummy live over there. So that's why they're.
Oh, okay.
They started
Unfortunately,
translating it.
Oh, it comes to that. Okay. So there was one concept called as Pendleton's feedback, and people don't like it because it's a bit unrealistic. Like you were saying, okay, in the middle of the list, is it realistic to? In that feedback, it's like you have a conversation with the trainee saying that, what do you think? What are the good things you did? Okay, and then the trainee says that, okay, these are the good things I did, and then the trainer will add to say, okay, yes, but what are the other? These are the other good things you did. And then the trainer will ask the trainee, what is it you could have done better? And then the trainee says, and then the trainer acts and says what else they could have done better. But that's not very realistic all the time to ask every time. Okay, so how did it go? What are the good things? And then the trainer mentions that. It's a bit disturbing, isn't it?
And disturbing me है दूसरा नमाज का टाइम हो रहा है. If you can take a break
Okay.
for 10 minutes.
Please, yeah.
5 minutes.
Oh, of course. Yeah,
It's a great idea.
Why did we do that? Yes.
नहीं 1:15 पे. तो वो जो करके बस we will come back
Yeah,
as soon as.
yeah.
Is that okay?
Yeah.
Thank you. And then in the meantime, Shahid will adjust this.
Yeah. It's a bit.
So I was meaning to ask, when encouragement and we need to create a mix. If we
Correct.
keep on encouraging too much,
Yeah.
and this is what do you do?
Okay, so
That's when they stop
that's-
following instructions.
That's when we come to the concept of this one, and then also those was a performance enhancing feedback. That's a more realistic kind of. Oh, thanks. This is better.
Yeah, I told him to close
Close this. So there is a concept called performance enhancing feedback, wherein and then performance in the middle of in the list. It's very unrealistic to do this. Come on, tell me what are the good things you did, and then you tell them what are the bad. What is that you'll improve on? That's not realistic. Rather than you just saying that how was that. Most of the time, the trainees will tell you, oh, I struggled there. No, that's okay. What are the things you could have done better? And then you just give 1 or 2 objectives to improve that. So for example, you got an experienced trainee in between the list, and the wire falls out, right, from the balloon. You got a stone out, but the wire fell out, but the balloon, with the balloon, the wire came out. And why do you think the wire fell out? Because you were too away from the ampulla. So when you need to come back closer to the ampulla as soon as your balloon comes out, so you can instruct your nurse to deflate the balloon immediately and then tip up immediately so that you go closer to the ampulla. So you're just giving him 1 or 2 methods why he came out. So the next time you make sure that you do this. So next time you make sure that whenever you are getting your tip down movement to get your stone out, as soon as you tip down, the stone's out, you tip up immediately and you ask your nurse to deflate immediately. Then your wire will never fall out. So I think you can just have that little bit of a discussion, that is you're giving 1 or 2 things which is going to change what he does next time. So that's a performance enhancing one.
Now, I just wanted it's good to clarify a little bit. While we will definitely talk about the performance enhancing feedback, while training trainees, I have lot many trainees. So what I see in them is everybody has a different rate of retention of their skills or acquisition of skills, what I would say. So what do? Do you give them extra time? Do you give them extra attention? If somebody who's struggling, and in the worst case, failing to improve. So do touch on that, what to do in that scenario.
Okay, so you're talking about a trainee where you think they're not progressing.
Yeah.
And then you don't think they've got the skills to progress.
I don't think that there is anything that somebody has not got skill. Maybe I'm not teaching them correctly.
Yeah.
And those who are shining, they're probably shining on their own.
Correct.
It feels like that.
Yeah. So I think there is, again, I don't know what's your setup is. In our setup, we've had a situation, we'll have 2 trainers teaching the same trainee. Then you always discuss with your other colleague. So what do you think? I think he's not progressing.
He's not progressing. If he's not progressing with both, okay.
I think it's important to have a discussion with your other colleague, whether it's me or whether the other person also feels the same.
Okay.
Because I've had a situation where other trainers come back to me and said that I don't think he's good for it. But no, I said no, I think he's okay. I think we just need to give him time. And then you persevered, and then he agreed with you. And then or you have a mutual dialogue that actually gives you more. It's because asking someone to completely stop is very difficult.
Very difficult.
Very difficult. Again, in this setup, if you say no, he'll go and do somewhere else. So.
It's not about that, but in my setup, actually, the thing is they cannot go anywhere.
Okay, that's okay.
That is wrong. Even if you ask them to go somewhere else, they don't go.
No.
And what happens is that we are stuck. So what I was planning was for them was that if they're not like somebody, if I see them that they're not made for ERCP,
correct.
so I would rather put them on
somewhere
colonoscopy, or I put them on manometry, something like that. So when to do that? So you've answered my question that if I'll get them assessed separately from another colleague of mine, if he still thinks the same. So
one of the other things we all have is we all, as human beings, we all tend to reflect. We take some time, or sometimes we don't have time. We're running around. We don't get even time to sit down and reflect on it. Every time we do, we always realize that I could have done this thing slightly differently, or I could have done this thing slightly. So as long as the trainee has an insight, and as long as you encourage that reflective practice, look, okay, fine, I'm just going to think about it. Maybe if something hasn't gone right, just maybe go and reflect on it. And then next time when we meet, or we put it in your portfolio, write it down. There's a DOBS form, there's an objective, just a reflection on it. Just reflective practice. So see, what are the things that helped me in calibrating the previous case, but what did I find different in this case where I couldn't calibrate? So what actually was it under time pressure? Was it a difficult stone disease? Was it an altered anatomy? So they reflect on the practice. So the more they reflect on their practice, the more, because I'm sure Sesha will touch upon that adult learning theme where it is always kind of self-motivated, and they're all driven, and we all are driven. That's what I don't know. Please get me wrong.
Some training, I think when you debrief them, they will have the insight. As Risha said, that you don't ask the trainee that you did this bad or you did that. You just ask them, what do you think you did good? Every trainee will tell you, no, I couldn't achieve this, I couldn't achieve that. They all talk about negative. Even when we were training, we would always talk about negative.
we used to do that.
We always talk about negative. So you say, what do you think you achieved? You did good. Okay, and then you build on. Okay, what do you think you could not do it? And then say, I could not position the ERCP scope next to the ampulla. And then some trainees will have an insight. So you say, okay, what do you think you were doing wrong? And they would say, if I had done this, or if I had moved my position like this, then I would have been able to do that. And that's the learning content, because they have the insight, but because they can't verbalize, and when they are doing the procedure, they are so stressed out that they have to do it, so they forget about it. So that is one of the feedback.
I think what you mentioned is a really important thing, because it's very difficult to us. Very difficult. But I think what both were mentioning is the most key is the insight. But some personalities don't have that insight at all, and that will come in. Some people have no insight into themselves and has no reflective practice, and that is when alarms will start ringing. Okay, they've done something wrong, they're not progressing, but they still feel I'm doing great. But then when you have that kind of personalities, then that's when you need opinion from others as well. You feel the same, and then that's the time we have stopped people. But then more and more we have actually just on the model training itself. When we do the model training, we rank them who is the best, who's good, who should go first on the hands-on course, because we think that he's got good.
This is objectivization of this all over.
And then you know that.
I can give you an example, because you probably trained a lot of more trainees than I have. But one of my trainees has been with you. The one you trained from Ultan. Faisal. He just shined like anything when he went with Dr. Nadeem. And while hair probably was holding back on him or something, because there was a different trainer at that time, but when he went to Southampton, probably was it Southampton?
No.
So he just shined like anything. I'm sure he's doing a good job wherever he is.
He's a consultant.
Because I know a consultant in a region, so he's actually doing as a locum. But again, those kind of personalities are there. He's no insight at all. So on the CV, he has come back and said, I can do ESD. Okay, he'll say, I do ESD. 5 years ago, he's gone to Japan and did some hands-on there. In the last 5 years, he has not done any hands-on. But in other hospital, he has directly gone and did the cecal ESD perforated. And he has come to another hospital and said, I want to do ESD. Patient selection is bad. He's got no insight how much skills he has got. And the person has observed and says, he's really bad. He can't do proper EMR. But he has complete no insight. He's gone to 20 courses all around, paid thousands of pounds, and he thinks he is an ESD expert. So, and then that alarm bells started ringing. Now they have been completely said whether we should just stop him even doing EMR and just put him on service list. So those are, there will be personalities, and the more earlier we recognize them and say that you can't, he's not cut out for ERCP. His decision making is poor. You have done all the right things, but he has not progressed at all. He's doing the same mistakes and again. Then very rarely you'll have to ask somebody to show. But it's a difficult decision. But so having another colleague on board, making sure that you're taking the right decision, is important.
That is where
Because,
the self-training part hits you bad.
yeah.
You don't know what you're doing right and what you're doing wrong.
Because I remember
It's not about the numbers. We're doing like 800, 900 ERCPs a year for the last 3 years. Our total procedure count is beyond 5,000 ERCPs, and independent is like 1800, 1900 logged है और unlogged तो बहुत सारी हैं. जिनको train किया और जिनको who are जो attached हैं वो तो probably शायद वो हमारे software में provision नहीं है, वो 2 जगह से count नहीं करती, वो it just counts one जो operator होता है. तो but some of my trainees जिनको मैंने खुद से सिखाया, they are very good, बस सिर्फ उनके pancreatic procedures जो हैं they are about to go into them, or but 2 of mine जो हैं वो they are not progressing at all.
One is insight and whether they are safe, and they asked her for help. This is very key. Because I had one trainee, I remember where my other colleague said, I'm not going to train him. He's rubbish. And he's also past the age. He's now 50 plus. Why are we training him? I said, no, he's safe. He's taking his time. He's just very cautious. And he asked for help. No, let's give him time. I think if he wants to persevere, he's safe. Most important is safe.
Now your safety is
And
good.
he knows it.
I would always prefer a safe training
person.
over somebody who has his foot on the cautery.
So let's give him time. And then actually now I'm looking back, I'm happy that I supported him, because in a hospital where he's doing, he's the sole member who's doing provide the service. And if we had not trained him, it would have actually affected the region. So looking back, I felt I did the right thing.
So that was a service to the region then.
Exactly. So
Todd Barron, do you know what age did he do his first year CP?
Probably at
56. Todd Barron.
So let's talk
Third
about
barrel.
lunch break. No?
are we?
No.
Oh, is it? Okay.
Because 1:30 was lunch break anyway. So
Oh, it's changed.
Okay, by the time they come, they will take lunch.
But they're good stories. They help us just stay on the path. They help us stay on the path.